Hey, tech enthusiasts. Thank you for joining us. Today we'll be talking about the Nebraska Health Information Initiative with special guest Deb Bass on this episode 9 of TechBus. Deb, thank you for joining us. As always, we're broadcasting from the TechBus studio at Linkstream. My name is Tomas Contreras. I'm the Director of Talent Strategies for Linkstream.
And I'm Thomas Pizzo, the founder of Linkstream, an IT consulting company that offers contract resources, custom development in the developer cloud.
Awesome. We have a special guest, Deb Bass. She knows a little bit about that, but mainly we'll be talking about some medical and the health system. But Deb, before we came into the podcast studio, we're talking about 20 years in consulting. Can you kind of give us your background and kind of how you came into the full circle with this medical?
You're going to incriminate me as far as my age. I started working when I was 5. I was a registered nurse for years at a hospital. I was almost 17 years at a hospital, 11 years in the operating room. So I had an opportunity to see the importance of information, timely information, complete information. During that time frame, I was also finishing up a healthcare administration degree and was exposed to technology through that coursework and really began to question why was there such a lack of technology in healthcare, and we were just extremely paper-based at that time. Yeah. So part of that coursework called for writing a business case and then a business plan. So I was just attracted by technology and what was happening, Y2K was looming, and wrote a business plan to start an IT consulting company, which I did in 1993. Had that for right at 20 years, sold it, but I was anxious to get back to healthcare. At that point, things were beginning to change, and I was really excited about bringing what I had learned in IT consulting back to healthcare to make some of those changes happen.
Can you talk specifically about the initiative? I know it says here it began around 2005. What was it then and what is it today?
Certainly. In 2005, a group of individuals from across the state started meeting, and we were just beginning to implement electronic medical records at that time. And already they were beginning to recognize that different hospitals and provider and physician offices had selected different software packages, and they couldn't talk to one another. So granted, they were beginning to capture the data electronically, but it was only within that hospital or that physician's office that they could use the data. And people don't stay in one office or one hospital. Right. So, or if they're driving across Nebraska and they become ill or there's an accident, you can't get that information. And so quickly they began to realize that we need to figure out a way to exchange information across all of these systems. And the original concept is that we should just select one electronic medical record and everyone should use that. Well, of course, by this time, major investments had been made at some of the large health systems, and it was difficult to decide who was going to win the war as far as the most comprehensive electronic medical record, because this industry was slow compared to others to adopt technology. Yeah. So there were many siloed parts and pieces. And it was really difficult to write an application that addressed the expanse of healthcare because there are so many connections and so many different kinds of services that are all siloed.
So some of them provided what it needed, but they didn't have this. The other one had this, but it didn't have the other part. Okay.
And as a result, information would be locked, and you couldn't access it in case of an emergency. Prime example is what medicines you take. To this day, we're still struggling to get medication reconciliation software that is all-inclusive, real-time. Do you include over-the-counter medicines? Do you include the herbal medicines? What about the nutrition stores and some of the supplements that they sell? Where does it stop? Yeah. That's an example of that. So anyway, back to NeHII. So several conversations. At that point in time, from 2005 to 2007, a concept was emerging called Health Information Exchange. Okay. And many individuals don't understand that NeHII is not an electronic health record. It is health information exchange. It's the Expedia model for healthcare, where we enter a patient's name and birth date and send crawlers across our system to identify the matches using a master patient index and record locator service, and then bringing all of that information into view for the provider, and that happens within seconds.
Wow.
So it's real exciting, and it was brand new in 2007, 2008. So I started consulting with NeHII in 2007 and continued to work with them, and then became a full-time employee in, I'm trying to think what year that was, 2012.
Yeah.
So,
And now you're the CEO?
yes.
So what were, go
Can I
ahead.
jump in? I had a question kind of trying to solve that problem of having all these different systems, and maybe this is kind of already where you guys are going. Isn't the solution not necessarily a single vendor, but a single format of how information has to be transferred and formatted and
Standards.
standard? Yeah,
Right.
basically, RFC standards or something like that.
Right,
That
exactly.
have been around the internet since its inception. Is that the direction things are going, where it's just about standards and formats, not necessarily you can use whatever vendor you want or whatever?
Correct.
Okay.
And we're still struggling with standards in healthcare. And the language that we use is HL7. And as a business developer, you probably have never heard of HL7. Exactly. And so it's very unique to this industry. And the standards are still somewhat loose. They have been developed, but do all developers follow those standards? Even every hospital will populate. We use one of our most important ways of connecting this information is called an ADT feed, admission, discharge, transfer. So it's basic patient demographic, but it's also their diagnoses. All kinds of information can be stored in there. But because hospitals populate that differently, we struggle to get the standards so that we can compare apples to apples when we're using these ADT feeds.
Now, when you say standards, is that, because I think looking at the website, this was a statewide thing. Are these standards something that are being implemented on a national level or on a state level?
Yes. And have you heard of Meaningful Use, the Meaningful Use certified? Electronic health records are all now required to go through a standardization testing certification process, and it's called Meaningful Use, a certified electronic health record. And physicians and hospitals are required to use these certified EHRs, electronic health records, and then they can submit quality reporting data that they are using it. They're using it to accomplish certain things, and the federal government will reimburse them. And that's the whole meaningful use. The NeHII Cooperative Grant Program, the ARA that was passed in 2009, all of these federal programs came about because the federal government said, we need to get our arms around this. It's a problem that is growing, and there was quite a bit of work that went into getting these standards in place. And yet we're still finding situations where it is a certified, meaningful use electronic health record, but it does not follow all the standards.
So the government isn't telling people that, or companies, that they have to do this format, but they're just giving incentive to do it?
Correct.
Okay. Do you think that's eventually going to come, though, where in order to be, a electronic medical record system provider, you're going to have to format your data so that it can be consumed?
It is pretty well there because everyone was interested in getting these incentives. And plus the systems that, like for instance, us connecting to electronic health record, the health information exchange, we won't connect to you unless you're certified. So if you're not certified, you're living in a pretty small island that is shrinking all the time because that's where the industry's gone.
Where are these standards at? Like, are they documented so that anybody can access them?
Certainly. There's several organizations that house these standards. NIST as one, and there's all kinds of interesting acronyms that, different standards organizations that build these standards. The federal government tries to collect those. CMS, the Centers for Medicaid, Medicare, ONC, the Office of the National Coordinator, all of these federal agencies are working to develop these standards so that we can talk to each other using the same language.
That's cool.
I know almost 12 years later from 2005, I know in the medical world, that's just a blink of an eye because how long it takes. What's been the biggest hurdle you've had to jump over to kind of get this, which to me it sounds like a great thing. We all need this. This is pretty simple and plain. But what have you seen? What's been your biggest roadblock so far?
It's been very fascinating for me because this was brand new technology, and the industry was evolving from if we own patient data, we own the patient. And healthcare is it's a very competitive industry.
Yeah.
And so, first of all, there was just that concern about if I open the doors and start sharing data, am I going to lose patients? We quickly demonstrated that patients saw value in having their information shared.
Right.
And if anything, it helped with loyalty. But still, patients move all the time. There's about an average of 30% of attrition moving all the time, your population base. So first of all, it was convincing individuals that sharing data was a good thing, and organizations. And I will commend the healthcare professionals in the state of Nebraska. We're one of the leading health information exchanges in the country.
Wow.
Again, we don't do a good job of blowing our horn, but on the national scene, we're frequently referenced as, look at what they're doing in Nebraska.
Wow.
And then all of the skills that I learned from having that IT consulting business, and then working also with government entities and federal grants, and building the airplane while you're flying it, literally.
Yeah.
There were days where, we're a public-private collaborative managed by a board of directors with both state representatives and private industry, with multiple competing agendas. And just being able to thread your way through that. Many health information exchanges struggled with sustainability. I'm proud to say we are sustainable and have been since 2012. Just figuring out how to turn the lights on every day versus putting very complex IT systems in place. Working with consent, educating people about, you can decide to have your information shared or not have your information shared. And then the standards question, just hammering almost every implementation. You're dealing with some level of standard implementation that you're having to test and validate that the data is in the right place.
So let me make sure I understand what the business is. You guys, if a patient goes from hospital A to hospital B, your system will take the information from their electronic medical record system and then transfer it.
Right.
However whatever hoops and things it has to go through to communicate.
When we bring on a new
bridge.
participant, we take a copy of all of their data, their electronic health record data, and then we store that. And when a patient presents for care, the provider enters that patient's name and birth date, and we identify all the matches across all the systems and then bring all of this information into view. So
it's almost like a search engine for health records.
Correct.
Okay. So you have like these crawlers going out there looking at all these different systems.
Yes.
How do you get past, I mean, that seems like a tricky thing for HIPAA concerns because you're just crawling systems looking for data that you might not necessarily have the right or the need to be into. How do you overcome that?
Well, and that's what I was referencing when we talked about consent, because we had to develop privacy and security policies. We also have to protect this data. We can't let people bad guys get in and take a look at this, and because health record is now becoming more valuable than your financial records for some of these reasons. And so we have privacy and security policies. Those were developed in 2008 here in Nebraska. And I'm proud to say that more than 30 different health information exchanges statewide and regional have used our policies to develop their own because we were so far ahead of everyone else. We had to understand how we were going to work with consent practices. How are we going to educate consumers that this is what we're doing and keep it simple enough so that they can understand it. Look at the time we've just spent as I'm explaining what the system does.
For sure.
And how do you make that understandable to, sixth grade reading level, but bilingual, all of those kinds of things. And then help them to understand that this is important and that it is very valuable to them to have their information in the hands of their providers, particularly in an emergency setting. So we have what's called an opt-out consent model. Patients are educated. We have a website that's available 24/7. Log on to the website. They can change their consent status. And what happens if they don't want their information shared, the system is configured or, quote, blocked so that the provider can't see the information in the system if they don't want their information shared. If they do want it shared, we remove the block. We never remove information because we do have individuals that change that consent status on a regular basis. And when they do want their information shared, we want it there. The good news is the opt-out rate is 2.32% for Nebraska. That's another stat that is talked about nationally because Nebraska is viewed as being pretty conservative. And yet consumers understand the importance of this. But back to your question about how do we protect this with HIPAA, it is only for healthcare professionals. You must have a treating relationship with the patient that you're looking up, and we have audited systems. We know every click. We know who's looking at what. And if you have, if there's someone that's abusing or violating the policy, we know it, and we pay a visit. So, we do make certain that there's a right, that patients' rights are respected, and that there is a relationship before someone is looking at that information.
So does your system at some point, let me understand, if you're just taking data from one electronic medical record system and putting it into another, couldn't your view into all these systems almost become the electronic medical record system? Because if I'm able to just quickly look at that, search across all these systems, doesn't that almost kind of bleed into replacing the medical record system on their system?
It's a great question, because many of the electronic health records are calling themselves health information exchanges, and they have certain tools. But the electronic health record takes a very deep dive into all the data that's collected on a patient when they're in the hospital or in the provider's office. As health information exchange, we're looking for that broad view, pulling lab results in, pulling transcription reports, and those are like admitting reports, discharge, emergency room visits, progress notes, radiology, the results of radiology tests, and then basic demographics. We have a bit of a different focus, and because we have this master patient index, record locator service, it's a different technical functionality than an electronic health record that is usually building a data warehouse, if you will. Mm-hmm. And we're going to get into some real technical hybrid federated versus centralized data model. Those are some of the differences that you have between the electronic health record and the health information exchange.
Yeah, but I could still see those worlds starting to bleed into each other at some point.
They do, and they are.
Yeah.
How do you get, so say for your person going to the doctor, how do you enroll in this, or how do you, is this at the bottom of our forms that we're not reading?
It's actually in your authorization,
Okay.
right? That you're probably not reading.
we just saw that you just signed it.
So read your forms,
right,
guys.
It's right there, and we're handing out brochures.
Okay.
So it's a red and white brochure, and it talks about why health information exchange is important. But I want to go back to your question, Thomas, that yes, there's bleeding that's happening, but the question I'm going to ask you is, as a consumer, these electronic health records are for-profit, privately held. Well, some are public, but they're for-profit. NeHII is a public-private collaborative nonprofit. So our job is to do what's right, community betterment. And, you know, most of these electronic health record organizations are for-profit entities. And are they interested in building their business versus really serving a consumer?
Okay. So you mentioned, before we started the show, you mentioned that some of these vendors charge fees for extracting information. Is that legal?
That's
to do?
exactly what I'm talking about.
Okay.
Yes, it's very legal. They're for profit. I was having a conversation with one that I thought was charging a very ridiculous fee, and he said, "You don't understand. I'm not in the business." And I was trying to use the plea of, "We're all in the business of patient safety," and that individual explained to me immediately, "You might be in the business of patient safety, but I'm in the business of making my stockholders happy, and that's for profit."
Okay.
And, you know, those are, and these interface fees, and if you've been in IT, you know what I'm talking about, an interface so that one system can talk to another and you can exchange data. You build one, and then you can take that. Yes, you tweak it, you know, with every new connection, but if it's well built, the major effort is in that first development effort.
But doesn't the patient have rights to that data, or does the vendor? I mean, is that where the legal battle comes in?
Yes, that's many. But, you know, in the end, the patient owns their data. And I will say, yes, and I will say that's where the healthcare industry, when I was a young nurse many years ago, we didn't let patients see their charts. And I know that sounds bizarre, but patients were not allowed to see their charts. And even to this day, you know, providing medical records to patients, there might be notes that a physician or a provider will, you know, write in the chart that the patient might take as, you know, offensive. And it's just time is limited, and, you know, you get to the point when you're writing notes and you have 15 minutes to see a patient, and you don't always have time to be flowery if they're not, you know, following the treatment plan or not taking their medications, et cetera.
So, but even as a patient, if my information gets entered into a system, say at Hospital One, and your system is wanting to extract that, and I've given you consent, aren't they obligated to release that information? Or, you get what I'm saying? Or they're saying, well, we're still having to provide the technical know-how and whatever to do that, so we have the right to charge a fee. Is that
Right.
is that like in the courts being battled out, if that's even legal to do that? Because I
Well,
can see where you could say that's not their information.
Right. And I will say that, you know, the federal agencies, the Office of the National Coordinator, CMS, they know the problem. And, you know, they have what's called the wall of shame, and they talk about some of these situations that, you know, what the electronic health records are charging for these interface fees. And, you know, it's a prime revenue generation tool for them right now. And knowing that we all have to connect to each other, but I mean, you can understand the number of interfaces that are required when you think of all the providers' offices, the hospitals, the radiology centers, the nursing homes, the wearable devices that you want to have your information entered into that's all an interface. And that's where, you know, health information exchange, once you build our connection, you're done. You're not constantly working on, you know, with a new version, an upgrade, an interface has to be tweaked, and there's another fee kind of thing.
Mm-hmm. Okay. So how do you, well, let's maybe take a quick break. We'll come back. You guys are, you know, not necessarily for-profit business, but I assume you got to pay the bills somehow.
That's we do.
Maybe we'll dive into that and talk more about your mission and how you guys operate.
Great.
So be right back.
Thank you.
right, welcome back, guys. Here in our second segment with Deb Bass. Before we went on the break, we were about to talk about how the organization's structured. Maybe you could explain more about like your particular role and how the hospitals and everybody involved, how that's organized. So
Certainly. Well, I'm the CEO. I report to the board of directors. There's 16 members on the board of directors. We are a 501c3 nonprofit public-private collaborative, which is a lot of words. But
how many times a day do you have to say that?
quite a few.
That might not all be on the title of the podcast. Might have to leave some of those words out.
But what it means is that we have representatives from insurance companies, physicians, consumers, labs, X-ray centers. We try to get cast our net very broadly to get all the stakeholder participants involved in making these decisions. We have a board of directors, and then we also have 7 different councils and committees that have their own focus: a consumer advisory council, a professional association advisory council, a technical committee, a finance committee, yay, executive committee, and they all meet monthly. So I have like 9 meetings a month of just the board and these committees. And yet, I will tell you, the work that's come out of all of these councils and committees, it's helped to build the engagement. People are committed to what we're doing. It is just an opportunity that, it's bleeding edge. And these are all operated by volunteers. And I have to thank them because, as I said, our policies have been used as models across the country, and that was all developed by a bunch of people coming in the room when we were working on our privacy and security policies. We were having a ribbon cutting that was hosted by Governor Heineman in 2009, and we were working on our privacy and security policies at the end of 2008, and we were selecting a date, and we had to get back to the governor, and I had to say, because we couldn't decide on certain things, I said, well, we have a call with the governor here in about a few hours. Like, we need to get some of these things decided. And everybody just sat down and started figuring it out.
Yeah.
And when I travel and speak nationally about what's going on here, people say to me, I don't know what it is about Nebraska. They just know how to roll up their sleeves and get things done. Awesome. And yes, it is. And we're typical Nebraskans. We don't toot our horns very well, but the national recognition that we're getting is pretty exciting. And that's something I forgot to mention in the 2005 discussions. This was an initiative that was led by the Omaha Chamber of Commerce and the University of Nebraska, and it was to stop the brain drain, because we had great medical facilities that were turning out all kinds of healthcare professionals, and they were all leaving the state. And then the chamber was involved because they also thought we had a tremendous economic development opportunity because of the expertise that we thought we would be able to develop by coming together like this and saying, look, we need to start sharing this information. So that's very interesting history when many of the other HIEs across the country came together because of the ARA. That was the federal funded grant, and so they didn't have that onus behind them for economic development or to stop brain drain from their state.
Kind of circling back, you talked about talking national, nationwide. What's one of the biggest talks you gave? Where was it at? What was it about? And also, can you tell us a little bit about your speech this year at Infotech?
Certainly. I've been asked to speak at a number of national conferences. Some have been as large as 200, and then some are smaller groups. The other thing that NeHII does, we were the first state that incorporated what's called prescription drug monitoring. We're identifying drug seekers. And so now I've been asked to speak quite frequently on that topic because we were the first state that said, here's another example of healthcare. We have what's called the Prescription Drug Monitoring Program, and their registries, and they just capture the controlled substances, the opioids, in a registry. And so the provider has to, first of all, log into a second standalone registry and then look up this information on a patient while he's trying to treat them and working in his electronic health record. So he's moving back and forth. So we said, wouldn't it be easier if you just had all this information in the Health Information Exchange? And we were the first state that passed a law to do that in 2011.
Nice.
And we've continued to build on that, and we're getting several grants now and recognized nationally for the work that we're doing.
Nice.
So that's been another topic that I've been asked to speak on. We're also the first state that has now, last year we passed LB 471, and we've been so bold as to say we not only are going to mandate the reporting of all controlled substances, we're going to mandate the reporting of all medications, because there's significant loss of life and expense involved with medication errors. And it's called adverse medical events, and there's all kinds of stats out there about what it costs the healthcare system when people are given the incorrect med or they're taking it incorrectly. There's all kinds of wonderful pharmaceuticals that are available to individuals to treat all kinds of medications, but interactions between meds or improper dosage, as there's many individuals have been damaged by them as well.
Yeah,
so
I can imagine.
that's why it's so important, and why your providers, whenever you enter any kind of facility for medical treatment, they ask you, what medicines do you take?
Right.
And yet I found that interesting as a young nurse, that we're asking individuals that have no healthcare background, what medicines are you taking? Because they usually, it's a little blue pill,
Yeah.
and it's a
Guilty.
Yeah, right.
Guilty.
And yet you have no idea how important it is that your care provider, especially in an emergency situation, know what medications you're taking.
For sure. That's really cool.
So one more question here before we wrap up. Some of the challenges you're facing, do you think you face more challenges on sort of the bureaucracy side or some of the technical challenges? Is the technical challenges not that tough?
No, they're not that tough.
Okay.
We've been in it long enough. Granted, it might take some development effort and some trial and error, but as you know, you develop, you test, you fix, you keep moving. The technical capabilities have been there for a long, long time.
Yeah.
And it's
just
really
navigating
frustrating.
all of
It
the-
is. Consent, privacy, security, the governance, because there's always the question, who, quote, owns this data? And I'm going to live my life trying to get rid of the phrase, who owns the data? I talk about data rights, that in order to share data, we all have to agree that we all have the right to share the data, and this is how you're going to view it, and we have a mutually agreeable responsibility to protect the data, keep it private and secure. But to really serve our patient, it has to be shared. So if you're trying to tell me that you own the data, it means that someone doesn't own it. And so that whole phrase of data ownership.
So how popular are you among the CEOs of EMR software companies?
Not at all. And it doesn't bother me.
Yeah.
It's patient safety. And again, having been a nurse, that is, that's your mantra in life. And
Do you ever go speak at their conferences just to get under their skin?
I do, and I've been questioned, and people have stood up in audiences and challenged me. It's happened several times, and I always go right back to patient safety. Are we in the business of patient safety?
Cool.
So.
Just healthcare to you, on a personal level, it's less profit, more about who we are. I don't know what you guys think. That's how I think
Right.
healthcare should be.
Taking care of people. That's why I went into it.
Awesome.
There's all kinds of waste in healthcare in our country, and there's a business reason behind every dollar. And so that business reason is going to prevent, they're guarding their turf, and they don't want to see some of these things change. So.
Well, thanks for coming and talking to us. Really interesting stuff. But usually at the end of the show, we let our guests share any websites or contact information or whatever our audience can know to find out more about what you're doing and maybe help contribute. So
Great.
if you want to share that.
Sure. Well, NeHII, we have two websites. One is for consumers, and it's our consumer-facing website. It's connectnebraska.net, and that is the site that you can log on to change your consent status. And there's no limits. You can opt in, opt out, however often as you're comfortable or concerned or whatever. And then the other one is NeHII.org, NeHII.org. And that is for more tailored for healthcare professionals. It talks about policies, procedures, all those kinds of things. And then with the prescription drug monitoring program, we partner with the Department of Health and Human Services at the state, and they too have a website that is for prescription drug monitoring, but also speaks a lot about NeHII, and that's at nebraska.gov. So.
Awesome.
All right. Well, thanks.